All right, welcome everyone. I'm seeing the live symbol there. Good evening. My name is Samantha Barth. I'm the program coordinator at the Prescott Public Library, and it's my pleasure to introduce tonight's Badger Talk speaker, Dr. Steve Barcy. Dr. Barcy has been a clinician educator who has worked in the areas of general geriatric care, memory care, and sleep disorders over the past 25 years. He has helped develop a number of new models of care for optimizing the care of older persons, including sleep education programming. He regularly speaks to community groups as well as groups of healthcare professionals on a range of age-related healthcare and adult sleep topics. And tonight, Dr. Barcy will be discussing the basic principles of sleep, health consequences of impaired sleep, and basic strategies for optimizing sleep. Dr. Barcy?
Yes, thank you. Thanks everyone for joining this evening. And hopefully we'll, through the course of the evening, kind of just do a tour de force on many different topics related to sleep. I think everyone that's on this call appreciates the value of a good night's sleep, and also probably the challenges when someone doesn't have a good night's sleep. So let me go ahead by starting out by talking just a little bit about what I mean by sleep. And so I think all of us at some level understand when someone's awake or asleep. And we spend approximately a third of our lives doing it. Some people a little more, some people a little less. More or less every living organism has some type of a sleep-like process that they participate in. And although most of us would think that sleep is kind of this passive thing that happens and where we might slide towards like being unconscious or even having being comatose, the reality is our brain and our body is very active when we are sleeping. Furthermore, unlike what many of us would wish, which is that sleep would be kind of like a switch which goes on or goes off, it's probably more realistic to describe sleep as kind of like an orchestra. And there are many different places in the brain, some that need to be kind of on, some that need to be off in order for us to kind of enter this phase. And so that's why, there isn't that quote perfect little blue sleeping pill that kind of goes and switches something on, because the reality is many different things have to be kind of in just the right way for us to be able to sleep. So moving along here, what we know is that in general, people who maintain healthy lifestyles, and that includes quality sleep, have in the long run, a much lower chance of developing physical and emotional disabilities. And so I think for that purpose alone, but as well as for us all to just feel like we're rested, it's very valuable for us to understand and think a little bit about how can we sleep better, and how can a person who might be struggling with a sleep problem get appropriate attention and management of that problem. So I'll start out by just kind of posing a kind of a question to the audience, just to think about, are you happy with your sleep? And this might be a corollary because you might have, let's just say, a bed partner, a spouse, or someone else. And you might also be, the question could be varied a little bit to say, are you happy with your spouse's or significant other's sleep pattern? And furthermore, if either you're not happy or maybe someone close to you is not happy, what are those obstacles that are there that are disrupting that sleep or decreasing the quality of sleep? So right up front, I want to toss out a couple of myths and debunk a few things. So there are a lot of people out there who are under the impression that inevitably, as we get older, we should assume that our sleep is just going to get worse and worse and worse. And as we'll talk about a little bit later, you'll see that, yes, there are changes that definitely occur as we get older, but it's not inevitable that you will have a poor night's sleep. Furthermore, others will have this perception that if you have a chronic sleep problem, there's probably nothing that can be done. That's just what you have to bear. And again, I think once you understand a little bit more about all the different things that can influence our sleep, you start realizing that there's lots of things that might be able to be tweaked or adjusted to help with sleep. So in general, what I'd like to kind of really emphasize during the course of tonight's talk is that everyone can probably find some ways that they can adapt their sleep habits and behaviors and attitudes, or maybe some concurrent medical conditions to improve their sleep. Now, I promise you, I will not, try to toss out too many data slides or things that look too complicated, but I'm going to walk people through a few of these things. So this here is a graphic that just talks about what, from several research studies, what we can anticipate might occur as we get older. And so on this slide set is in the percent section here is just a percentage of people who have a sleep complaint. And then you can see on the x-axis here some different age groups, 10 to 19, 20 to 29, and all the way across to 70 plus. And without getting too technical, you can see that those lines, that yellow line and that red line, both are creeping up. But interestingly, by the time people are getting into their 50s and 60s, you can see that it seems to kind of flatten a little bit. And what we do know is as we age, at almost every age group, unfortunately, women are a little more affected with sleep difficulties than men. And probably the most common thing that people struggle with is problems falling asleep. That's about 40% of all the complaints, followed by 30% of recurring nighttime awakenings, or in other words, staying asleep. And then there's some other things too, like daytime sleepiness that may be the primary complaint. If we think a little bit about, well, what, that sleepiness piece I mentioned, all of us have had days when we feel more tired or more fatigued. But what does that do as far as our health goes? And so there's been a number of surveys that have been done over time, asking large populations of individuals and inquiring, well, when you are excessively sleepy, how does that directly play out into your day-to-day life? And so you can see here that if a person's been sleepy 0 or 1 day in a week, then, following below here, you can track that about 1 out of 3 people might experience some minor mood symptoms, or they might cut back on their tendency to go out and socialize, or they may have a harder time focusing or concentrating on things they're doing. At least a quarter of people, if they've had a poor night's sleep, will avoid or getting outside and being more active or exercising on a beautiful day like today. Otherwise, just generally getting things done, or even just general work performance, all suffer. And then you can see, as you move over from the 0 to 1 day per week, all the way over to the extreme of 5 to 7 days per week of excessive sleepiness, that now you see really impressive numbers that all seem to be anywhere from 50% to almost 75% of people will have a negative effect or impact on these really core areas of day-to-day life. So yet another reason why we want to do what we can to help all of us to sleep better and have more restorative sleep. When we think about what are some of the influences or the effects of sleep disruption, again, there's a lot of science behind this. And I'm just giving you kind of very minor kinds of descriptions of some of the important areas. But I'm going to walk you through this little graphic here. We know that when people aren't sleeping well, that they have difficulties in regulating their emotions. And I'm sure everyone on this call can think of at least one, if not many times, when they were sleep deprived or just didn't get a good night's sleep. And the next day they were just a little bit crabby. And in some cases, people who have underlying emotional issues, that can be a pretty big deal. We also know coping with stress, minor stress things can also be more challenging. We know that ability to focus on and remember details. So this whole idea of cognition or memory can be affected. It also can affect our ability to sustain our attention for things like driving a vehicle or doing other important tasks. We know it has a number of influences on our blood vessel system throughout our body. And specifically, people who have chronic poor sleep and certain types of sleep disorders are more prone to have difficulties like heart disease and even stroke. When people are sleeping poorly, pain can be perceived differently. So literally taking someone, and if you give them a certain degree of, like let's just say put a shock on their finger. And if they slept well versus if they slept poorly, giving the exact same shock to two different people, the person who slept poorly will perceive the pain as more severe, more disruptive. We know that there's other things, such as our body's ability to control hormones and blood sugars. And with this, we now are seeing an epidemic of poor sleep in younger adults that may translate towards this epidemic we call, epidemic of obesity too, since we know that people who sleep poorly tend to eat more vigorously the next day, and especially carbohydrates, and that can translate to weight gain. So it's fair to say that sleep is a biological rhythm that is linked to the day and night. All of us recently went through this daylight savings transition, which was probably not easy for any of us. There are very few people that enjoy having that loss of an hour of sleep at night. We know that not only is it a biological rhythm, but it can be influenced by a number of other factors. We can override that feeling like we need to sleep at night by, giving ourselves, caffeine. We can be physically active. There's many ways we can try to override that. Also, if we're in the midst of some crisis or something, even if we're in the middle of the night, it's surprising how alert people can become. So we know that both there's a biology side to it, and then there's I would say, a psychology or behavioral side to it. And it's important that all those systems are kind of aligned for us to do well and sleep well. This graphic here, I could spend pretty much the whole time. I give whole lectures to medical students or even to health professionals about the science behind each of these things. But this is just pointing out what I had pointed out a little earlier, that we know that when we sleep, we modulate our immune system. When we're not sleeping well, we're much more prone to have, for example, develop a cold or have other problems. And I'm sure many of you can relate to that. We also know that proper sleep helps us to regulate our emotional state and our mood. I've already mentioned that when we go to sleep at night, we do a lot of housekeeping, where we take and we store certain memories away and we get rid of others. It also even influences our creativity. We know that it modulates a number of hormonal processes, and certain hormonal processes only happen when we're sleeping at night, like the secretion of growth hormone for children and adolescents. We also know that sleep is a time for our brain to have maintenance. And with that, a lot of byproducts that accumulate in our brain throughout the day can be kind of purged or removed from the brain during sleep. And as we'll talk about a little later, there's increasing evidence to even show that there's relationships between chronic poor sleep over a period of decades, not weeks, not months, but decades, may contribute towards more long-term cognitive disorders, even things like Alzheimer's disease. So let me keep moving along here. And I'm going to see if I can explain to all of you kind of a little bit of a teeter-totter that happens as to how we are able to sleep. So one thing that'll surprise nobody is the longer you stay up, the more tired you're going to get. And so this whole idea of sleep need, meaning the further we are away from the last time we slept, the more tired we'll get. And in the beginning of the day, and you can see this little alarm clock over here in the left corner, at 9 a.m., what happens is we've just woken up. Hopefully, we're probably about as alert as we will be through the day. Although it may not always be the case for people with chronic sleep difficulties. But as the day progresses, and as we stay awake longer and longer, certain chemicals build up in our brain that make us a little more tired, a little more tired, a little more tired. However, our body has a way with a circadian process of giving an alerting signal. So the longer we stay up, the more potent this alerting signal can get. And you can see that the little blue mound at the bottom is kind of compensating almost the same way as that little pink line at the top is slanting downward. Eventually, though, there'll be a point where our body's alerting mechanisms kind of start to reverse. And that happens typically in the evening hours. There's a bunch of hormones, including melatonin, that are part of that process. And so normally, when all of a sudden the alerting mechanism starts going down and all these chemicals in our body and our brain specifically that are going to make us tired have built up to nearly their maximum, that's the perfect time for us to fade away and sleep. But unfortunately, there are a number of things that can affect these two drivers, either this drive to stay awake or the drive to want to fall asleep. And if they're out of sync, then that can also make it hard for people to get to sleep. So do not worry about much of anything on this slide, other than I'm pointing out that on this little yellow graphic here, you see these red lines. And when we're awake, that's the very top red line. And you can see it's not very tall, but very kind of rapid. That's this awake period here. As we get drowsy, you can start to see that there's little spikes in our brain we can see this pretty clearly on brain waves. And then as we move towards the deeper stages of sleep, what we call slow wave sleep, you see the waves get to be, they're not very high frequency anymore, but they're very tall. And so through the night, we cycle between these different phases in a certain pattern. We spend most of our time in stages 1 and 2 sleep. We spend about a quarter of our time in deep sleep. That's those big waves, slow delta waves. And then we spend about a quarter of our time in dream or REM sleep. And I'm not going to get too much more scientific than saying that we have these different phases. And each one of these phases has important things that it does and helps with our body. So as we get older, I get asked this question over and over again. What can people anticipate might be typical? And what we know is that the amount of deeper sleep lessens. That doesn't mean people can't still have deep sleep, but the percentage might drop. So remember, I said 25% in the general population. As we get older, it could drop more towards maybe 10% or so in a healthy person, maybe. But in some cases, people still maintain very significant amounts of deep sleep. We do know that we have more of a tendency to wake up out of sleep. And I, again, bet that most people here can associate with this. So a little more transient periods where we wake up and then go back to sleep. Our total sleep time, maybe it becomes a slightly bit more variable. And in general, that clock that helps us to go to sleep, in many, not all, but many people might shift to slightly earlier in the evening. And this is why I'm quite confident that the 9 o'clock news exists. But in general, these are some things we'll see with all people. That doesn't mean, though, that the amount of sleep and the quality of sleep has to change, has to inevitably get worse. Now, to take a little moment further and talk about how much sleep do we need. So you can see at the very bottom here is a young adult. And young adults, the range goes anywhere from 6 to 11, with probably closer to the 9 hours range is ideal. As we get through most of our midlife and such, we're probably more closer to like about 8 hours. And as we get a little bit closer to older stage, you can see now the extremes dip a little bit more. And so some people literally might be sleeping 5 to 6 hours, but again, probably many people are sleeping closer to 7 hours. This is the need for sleep. So if you're someone who literally, as you've developed a sleep problem, maybe in your 50s or 60s or 70s now are sleeping 4 or 5 hours, that's not meeting your sleep need. And there, you'd want to seek out what might be going on and what could be done to improve or enhance your sleep. When we start talking about sleep, remember, as a behavior. So there's the biology side that I showed you earlier, that the accumulation of those chemicals that make us more tired, also the body's compensation by alerting you with other chemicals. But in general, what we can accept is that when there are certain places and certain situations that are better for sleep. So it's good when there's a strong association between, say, sleep and a bed. If the bed is where you sleep, or maybe it's a strong association between sleep and a recliner chair, or you can fill in the blank. There are people who sleep in very unusual places sometimes. In general, our mind should be throttling back, more relaxed, and with that, our body too. There tends to be an absence of active thinking when we're getting closer to sleep. Again, I'm saying things that I think all of you recognize. We know that there should be an absence of sleep disrupting substances. So there's all kinds of things that people can take that will make their brain charged up. Now, there are some people in the audience here who will say, caffeine doesn't do that to me. But what I will argue is that caffeine probably does to some small degree, but there are people who develop tolerance and can take caffeine in the evening. But generally speaking, caffeine will, and especially if enough caffeine is on board, will make it harder for us to relax to get to sleep. Additionally, the environment we're in can play a big role. So as a rule, darker and cooler and quieter spaces are better spaces. And so I ask everyone as they analyze, especially when I'm in my sleep clinic and we're talking about sleep issues, I'm asking people to describe their environment. What are the distractions? Do they have TV on? Is there bright lights and the street lights just outside with the window open? Is there noise coming from somewhere else? Is their bedroom warm? And that, for some people, that's not bad, but for most people, cooler bedrooms are better for sleep. Also, although exercise is a wonderful thing, and I would argue that exercise is probably one of the best therapies for just about every condition, exercise too close to bedtime can increase our core body temperature and activate certain chemicals in our body that are more stimulating. One other thing to talk about, I've talked a little bit about what is sleep. I've talked a little bit about the sleep need and why and how our body gets us to sleep. A question I get asked over and over again is napping okay? Is napping natural? And I didn't point out in one of the earlier slides, but there's a natural lull that affects all of us, anywhere from around, say, noon till around 2 or even 3 o'clock in the afternoon, where we just get a little less alert and just a little bit more tired. And that's the perfect time for a person to nap. And as long as a person doesn't nap too late in the day or too long, because the amount of napping you get in a day will be subtracted from the amount of sleep you would need at night. But what we do know is if a person sleeps or naps modestly, meaning somewhere maybe around 15 to 45 minutes in the early afternoon, it actually can help things like memory and evening focus. So I'm a big fan of napping, and I wish our culture would be. When we start moving from talking about what is sleep to thinking a little bit more about what are some of the things that can affect sleep, or do I have a sleep disorder, it's important for people to recognize there's certain questions that physicians or other healthcare providers might ask you, or that you might just want to bring up with your health provider. If you are not satisfied with your sleep, then that should raise up a red flag. If sleepiness interferes with your daily life, then that might also suggest a sleep disorder or something that should be addressed. If your bed partner a significant other, a spouse, a friend has ever observed you do some unusual things while you're sleeping, maybe abnormal breathing, maybe abnormal movements, then all of these screening questions might prompt you to have a conversation with your health provider. Now, I don't want people to get too distracted here, but this is a way that I try to teach about sleep problems to doctors in training, nurses in training, physicians out in practice. What I tell people early on is that sleep is a complicated process, and there's many variables that can affect sleep. And it's increasingly rare to find someone who has just one cause for why their sleep is poor. More commonly, what we recognize is that there can be several factors all playing a role in affecting a person's sleep. And in order to really help a person to sleep better, you need to think about all these factors. So in essence, I'm going to walk us all around this star over the next few slides. We'll talk a little bit about sleep habits that are not conducive for a good night's sleep. Talk a little bit about some chronic health problems and some of the medications we use to treat those health problems that can have a direct effect on our sleep. Furthermore, I hinted at that clock earlier on, and I mentioned that sometimes we all have a tendency as we get older to want to go to sleep a little earlier, but there can be more dramatic disruptions of that clock, and I'll talk a bit about that. Certainly, a number of psychological or emotional factors can influence our sleep. And finally, we know that there are a number of distinct sleep disorders that can cause a sleep problem. So I'm going to walk us through, and not, again, each one of these topics itself is could be a whole talk in and of itself, but I'm going to kind of give you what I would say is a sampler of what might be going on. So poor sleep habits. Our brain and our body is programmed for being routine. And anytime we vary or adjust our life schedule or our sleep schedule, and we can all think of examples of when this happens, it can negatively affect our ability the next night or the night after that to sleep. If we spend a lot of time in bed and we're not up and around, such as being in a hospital or in a nursing home, this is also a factor that can negatively affect things. I've already talked about the bedroom environment, excessive daytime napping. So a bit of napping is good. Too much napping, maybe not so. Lack of daytime activity and exercise. We know that has a direct effect on our core body temperature and other factors too. This whole idea of light, because as I'll talk about a little bit later, light helps our brain to kind of retrain our rhythms. So as we go from winter to summer, we can adjust our sleep gradually so that we are still able to sleep in both seasons. And a lot of this has to do with our exposure to sun and sunlight. And then finally, I've already talked a little bit about certain things that people can take into their body, caffeine, tobacco, and alcohol. They each have their own unique ways that they can disrupt sleep. Moving along here, when we start talking about these behaviors, especially people with chronic sleep problems, chronic insomnia, what we realize are that all of us have some risk for developing a sleep problem. Some people more risk, some people less risk, and that probably has to do with our genetics. What can happen is that a life event occurs, a health problem occurs, a major stress in one's life occurs, and that can tip a person from having a tendency to actually having problems going or staying asleep. Where people run into problems, though, is after they've had a few nights or a few weeks of poor sleep, there are a number of factors we call perpetuating factors that can reinforce those negative behaviors and keep us in chronic problems with sleep. And this is where a lot of very effective therapies can be used by sleep psychologists and counselors and others to focus on these perpetuating factors. And you might all say, well, I picked up this book. It was a great book from the library. And of course, I want you to be at the library as often as you can. But the idea of someone opening up a self-help book of any variety, and then assuming that by just reading that book, that they're going to be able to change their behaviors. In many cases, we need health coaches. We need someone to guide us and direct us. And that's where behavioral therapists and sleep psychologists can really play a role here. And this just shows you, these are little graphics. And so what I want to point out here is at the top is someone who had, all these people had chronic sleep problems over at least 3 months worth of sleep difficulty. And some of them, they were really, nothing was done, and their sleep problem was, the higher this bar is, the worse the sleep problem is. So you can see that if you do nothing, no surprise, your sleep stays poor. If you give people sleeping medications, it looks a bit better, the blue line below that. If you do a combination of behavioral therapy and medicines, it's even below that. And if you do behavioral therapy alone, and you do it with someone who's formally trained and understands the process, you can see the longest benefit. So I'm not saying that medications aren't helpful, but what I'm pointing out here is that in this and many other research studies, behavioral approaches for managing insomnia actually work as well or better than medications alone. So what is it you can all do in influencing your sleep habits and hygiene? As I mentioned earlier, stick to a schedule. If you shift your going to bed from 9 o'clock to 10:30, and it's sometimes as late as midnight and it bounces around, your brain is going to have a terrible time trying to figure out what's the right time to sleep. Not just your time you climb to bed, but it turns out that many activities during the day also can influence these biological rhythms. So our meal times, when we take our medicines, when we do our walking, when we retire to bed, all these factors can play a role. The napping, as I mentioned before. Napping at the right time, often in the early afternoon, can be very effective and helpful. But napping later in the day or extended napping, not so much. Exercise and activity can play an important role. I've already mentioned a little bit about things like tobacco and caffeine and alcohol. And each of these has their own unique ways by which they can affect things. I do want to make a comment about alcohol, because I think a lot of people will say, well, you know, if I have a drink before I go to bed, I get a little relaxed and I can fall asleep a little easier. And that's true. Generally, in most people, alcohol is a central nervous system depressant, meaning it slows the brain down, relaxes it down. However, the reality is that your body is going to start metabolizing that alcohol within a couple of hours after you've had your last drink. And if you have a drink before bedtime, then as your body metabolizes the alcohol, you'll actually go from one extreme of being relaxed to the extreme of being more alert again. So if you really pay attention, the next time you have a drink late in the day or in the evening, you'll notice potentially your tendency to wake up more often during the night, and maybe not even having as deep a sleep, will be higher. And that's why many of us in the field of sleep medicine don't endorse or encourage people to use alcohol before bedtime as a consistent and regular therapy. I've talked a little bit about, and I ask people to always take an inventory of what's going on in their bedroom. Where are the light sources? You know, nightlight is not a bad thing, but other forms of light can be. Where is that clock facing? Can you roll over, and every single time you roll over and you're not either sleeping or you woke up from sleep, see that clock face, right? That's actually not a great thing. And then the sound and the temperature, as I've mentioned earlier. Cognitive behavioral therapy is a whole area of sleep medicine. And it also is something that a lot of psychologists, some psychiatrists, and other mental health providers know about. Now, unfortunately, the number of people formally trained in this are not a large number. So throughout the state, there's probably places where there's more people with this kind of background and training, usually in larger metropolitan areas. And in other rural areas, it may be much harder to find someone who has the skill set to do this. But what I do like to suggest, I have one little piece of advice I often entertain when we're talking about behavioral approaches. Anyone who happens to be a worrier or has a very active mind, I usually encourage people to create a worry list hours before you go to bed. So if you go to bed at normally at 10 o'clock at night, maybe somewhere around 7 o'clock in the evening, go ahead and write down all the things that are active worries or things that are upcoming events in one column. And then next to it, what you're going to do tomorrow to deal with it. Now, it seems really strange to write these things down and also to write down what you can do about it. But then in the middle of the night, when you happen to wake up briefly and your mind starts going to all these things, you can just kind of feel more like, I've already dealt with it. And many times it helps people to kind of relax and throttle back down rather than really get going with their mind and engaged. Moving around those points to the star now, medical illnesses. There's a number of chronic health problems that we know correlate with poor sleep. Things like high blood pressure, moving along arthritis and the pain that's associated with arthritis. People have had strokes, people have COPD or emphysema. People are living with problems like depression or anxiety. You can see that certain conditions like depression, the numbers go up much higher and higher for the tendency for sleep problems. Many medications people take, and this, again, this is not by any means a complete list. This is where having a conversation with your nurse practitioner, your PA, your doctor, or your pharmacist can really help. If you're struggling with sleep issues, it's really valuable to say, do I have medications on my list that could affect my sleep? So things like cold medications, certain caffeine-containing pain medicines like Excedrin, medicines people take for their mood, in fact. Prednisone, which is a medicine that people can take for lung problems or for other kinds of medical conditions. And you can just follow this list down. This is only meant to point out that there's lots of medications that can negatively affect our sleep. And sometimes there can be substitutions with other medicines that'll have less of a negative effect. This just points out that there's a number of caffeine-containing medicines that have almost as much or more caffeine as a cup of coffee. So, for example, and I'm not saying anything positive or negative. I don't want to make you think these are bad meds or good meds, but I just want people to realize that there's a lot of meds out there that have caffeine in them. And some of them are almost a cup and a half or even 2 cups worth of caffeine. This comes to those rhythms I was talking about earlier, the internal clock. And we know there's all kinds of amazing things that happen in our body at different times of the day. So when we tend to wake up, that's about just a few hours before we tend to wake up is when we've had the lowest body temperature of the whole day. When we first wake up, those first few hours, we have the highest blood pressure of the whole day. Our best concentration is probably in the mid to late morning. We tend to have our best physical performance for exercise and activity in the later afternoon. And our brain is most prone to sleep, as I mentioned earlier, for various reasons in the evening hours. Oops, I apologize. Forget about this slide here for a moment. What I'm going to show you next is that bedtime can be naturally different depending on our age. So anyone who's ever had a teenager in the household knows, and not even just a teenager, maybe a 20-something-year-old, that they like to stay up late. And it's common for many younger adults to stay up late and want to wake up late. Throughout much of our adult life, the typical person might go to sleep somewhere between 10 and 11:30 at night and get up somewhere around 6:30 to 7:30. But as we get older, sometimes we can have a person move ahead so that they start getting much tired earlier in the evening. And if they go to bed at 8 or 9 o'clock, then they may wake up easily at 3 or 4. And they'll wonder, why in the world am I up before the light is up? But this could again be a phase change in our circadian rhythm. Moving to the fourth point on this little star that I was showing you earlier, there are a number of mental health conditions that can affect our ability to sleep. And it's very common for depression and anxiety to do so. And in many cases, as I'm treating or I'm evaluating a person for a sleep problem, I'm looking for hints of some of these conditions, because sometimes the best therapy may not be a quote sleeping pill, but rather something to help a person's mood out. I give whole talks on the relationship between sleep and dementia. And today I'm really not going to cover much of that, other than just saying that as our brain changes from conditions like Parkinson's or Alzheimer's, we can have common changes in our sleep rhythms. So now I'm at the last point on the star, and we're going to talk about a couple of these sleep disorders for just a few minutes. So there's actually, I have a whole thick textbook that describes almost 95 different sleep disorders. Now, the reality is that some of those disorders are very rare, but there's some of them that are common. And I guarantee you, people who are on this webinar right now have some of these conditions. So for example, sleep apnea. In the general population, 1 in 10 people have it, about up to 10%. But as we get older, that number can go up to 1 in 4, or even in some cases, 1 in 3. We know that condition like restless legs is a very common condition. By common, I mean maybe 10 to 15% of the adult population has it. And it gets just a little bit more common as we get older. Not as big of a change as that sleep apnea that I pointed out. And there's a few other disorders that I see a little more often in my geriatric sleep practice, and that includes things like that REM behavior disorder, where people can act out their dreams and jump out of bed and do funny things at night. And that's a certain type of what we call a parasomnia. And it's a relative of like sleepwalking or sleep talking, for example. So let me take just a minute or two. And I have to apologize because we did start just a few minutes late. So I'm going to try to zip through these next couple slides a little quicker, but I don't want to ignore them. We know that sleep apnea is a common disorder. It makes people really sleepy. It affects how they breathe at night. When they wake up the next day, they don't feel as rested. And not only does it affect how they feel, but we know that it affects things like nighttime urination, and it affects concentration and memory. So for all these reasons, we want to pay attention to this disorder. When there's different forms of sleep apnea, but the most common form of sleep apnea, called obstructive sleep apnea, when a person lies down and when they relax and fall asleep, then the tongue and some of the other muscles in the back of the throat kind of fall back, and it can make that space in the back more narrow. And that means that less oxygen gets in and less carbon dioxide or other gases get out. And that leads to this little picture here. When I have someone and when we hook them up with either a home sleep test or a sleep test in the laboratory, we can measure their breathing rhythms. And what we can see here is that if you see the little black circle in the middle here, see those flat lines? Well, those flat lines are each one of these little from bar to bar is about 30 seconds. So this is someone who is breathing, breathing, breathing. And then this first red arrow points to a flat space. That's almost 30 seconds where they're not breathing. And those little blue or aquamarine boxes down below show what happens to your oxygen level when you're having that pause over 10 seconds, 15 seconds, 20 seconds or more, as the oxygen dips way down. And then the brain doesn't like that. And so the brain wakes up temporarily, very transiently. And that cycle can happen over and over again through the night. Why do we care? Well, not only does it make people feel more tired out, but we know there's a number of health complications that are associated with sleep apnea. And again, I'm just giving you very, very brief commentary, but we know that sleep apnea causes high blood pressure. It causes heart attack. It causes stroke. It can cause some of these other conditions below, such as mood problems and memory problems. So I've mentioned that maybe 1 out of 10 people in the whole population, and maybe as many as 1 out of 4 in older adult population can have this problem. Does everyone with a sleep apnea diagnosis need to be treated? And what I say is not necessarily, and you might be shocked to hear me say that, because you might, have heard every single person who ever gets diagnosed with sleep apnea needs to be treated. And what I say is, if they're symptomatic, if they have medical conditions that we know will get worse with the sleep apnea, like a memory disorder or like a heart condition or high blood pressure, or if their oxygen level goes down low enough when we measure it, all those situations would say this person probably should be treated with one of different types of treatments. And I didn't talk today about those treatments just because I'm really trying to cover a lot of ground in a short period of time here. But I'd be happy to address some questions towards the end too. Another common sleep disorder that I regularly address in my sleep clinic is restless leg syndrome. And this is a condition where a person feels a funny, hard to describe sensation in their legs. For some people, it's creepy crawly feeling. For others, it feels like there's a tingling. I've had a person describe it as it feels like there's Coca-Cola bubbling through my veins in my legs. But it's generally uncomfortable. It happens in the evening hours. If we move our legs temporarily, that sensation goes away, but then it comes back. So it makes it hard for a person to go to sleep. Or if a person wakes up early in the evening, it can make it hard for them to go back to sleep. And if someone gets in a car ride and they've got this condition, boy, it can really torture them. What we know about restless legs are there's a number of common things people can do that are associated with making the problem worse. So caffeine can make restless legs worse. And so by cutting caffeine, it can help. Adjusting certain medicines that we know that make restless legs worse can also be helpful. And again, that's a conversation between you and your provider. Checking iron levels, because low iron in the body has a strong correlation between restless leg syndrome. And there's a lot of people out there who have restless leg symptoms because their iron levels are too low. And just by treating their iron levels, their symptoms can improve. So what I usually tell people is if you've got this problem, talk with your doctor about various treatments. It includes medication treatments. Now I'm going to skip because I want to be sensitive to time, and we did get going a little later. I'm going to skip a couple slides here. This is just a fancy slide saying that when we go to sleep, our brain kind of does some work to get rid of some memories and help with other memories. And I'm going to skip through this too, other than just summarizes what I was talking about earlier, which is certain phases of sleep. Deep sleep, for example, are very helpful for us storing away memories and then finding them later. And then other things are affected, like dream sleep helps us out with procedural memory. So like when you're doing something with your hands and your eyes, coordination kind of thing. So it's really interesting how different phases of sleep affect different phases of memory. The comment I made earlier on is that this is just kind of a picture of a brain. And what it shows us is that people who don't sleep well and have a lot of sleep deprivation have a lot of inflammation in the brain. And they also don't get rid of some of the bad byproducts as easily. And over time, not getting rid of those bad byproducts may contribute toward conditions like Alzheimer's. Now, I think we're getting close to the end here. I want to show, there's a lot of research out there that talks about social rhythms and physical activity and how this can play a role for sleep as well as for memory. And this is where if a person exercises, gets outside for sunlight at the same time every day, exercises, goes to sleep at the same time, and we measure their brain waves, we can see that their deep sleep increases. So yet another reason for getting out. And I don't mean people should go out and do something crazy like run a marathon always, but I mean just getting out for a walk or jumping in the swimming pool, doing jazzercise, whatever it is. So I'm coming to the end of my really tour de force talk about how it is we get to sleep, some things that can commonly make us have poor or contribute to poor sleep. And now I'm coming back to what is it you all can do as people in the audience, maybe some of you who have sleep problems or have loved ones who have sleep problems. It comes back to certain healthy lifestyle factors. That's those habits, those routines I was talking about. Early detection of diseases. So if you're having a problem where you're never getting restful sleep, even if you sleep 8-9 hours, that's a conversation that should come up with your doctor saying, I just feel exhausted or sleepy. That might lead towards evaluation with a sleep test, or that might lead towards looking at those points on that star that I was talking about earlier. It might mean adjusting medications. So there's a number of places that I send my patients to consider for what is it they can do, what's a reliable source. So the National Sleep Foundation has a wonderful website as listed here, www.sleepfoundation.org. And our own university here has a wonderful center on sleep and consciousness that I'm part of. And we've got another link there. And I'm going to leave this slide up for a little bit anyway. There's also some books that I find to be valuable, and my patients have found them to be very helpful. A book called Why We Sleep by Matthew Walker. The Promise of Sleep by Dr. William Dement. No More Sleepless Nights by Dr. Peter Horry. And then The Sleep Solution, How Your Sleep is Broken and How to Fix It by Chris Winter. These are all authorities who have tried to take complicated ideas about sleep and explain them in ways that all of us can understand. So with that, I want to thank you all for being good listeners. Sorry for a little bit of the delay on the front end. And I am very happy to look at a few of these questions, and I'm even happy to stay over just a little bit. I don't know if I'll be able to answer every one of the questions, but I'll try to do what I can here. So I'm looking here now, pardon me for scanning through the questions here. I'm going to go through the questions kind of in order of how they popped up and try to give brief answers for everyone. And then if we have a little more time, I can even go deeper. So are there certain vitamins and supplements that are better to take in the daytime versus taking before bedtime? Very good question. And again, this is a great question for your pharmacist, community pharmacist, or pharmacist in the clinic too. What we know are there are vitamins and supplements out there that can make us a little bit more tired. Some of the research suggests that they're very mild. So for example, you might hear people talking about valerian root. You might see people going out and picking up melatonin, which is that hormone that our body makes, but sometimes people take more. There are other vitamins and supplements that possibly could activate our brain. And I'm not a health supplement expert. But if I have someone who is taking a lot of health supplements, knowing that sometimes those supplements can interact with each other, I ask them to kind of reach out to either their community pharmacist or a naturopathic pharmacist, or sometimes other people who really specialize in these kinds of supplements to find out, make sure you're not taking anything that's very charging up in the brain anywhere close to bedtime. Magnesium is something that, well, if someone's given a lot of magnesium, first off, it's going to cause a lot of diarrhea, so you don't want to do that. People who get a lot of magnesium by the vein, it actually can make them somewhat paralyzed and such, and that's what they do for women who are going through premature, are given actually around delivery time to slow things down. Some very mild evidence suggests that magnesium may be helpful for restless legs. Some of the other areas, like just taking magnesium for falling asleep, there's not a lot of science behind it. If you're someone who's done that all your life and you found benefit, then I tell people, then don't stop it. But it's hard to know how that's working. Now, how does lack of sleep cause increased appetite? Great question. And so there's a bunch of hormones in our body that are linked to sleep and wakefulness. So there's one that's called leptin. And leptin is kind of like our thermostat in our body, and it controls, no matter how much calories you take in, it can kind of allow you to maintain a relatively stable weight, at least in the short term. But when leptin doesn't do its job, then people can gain weight with fairly small amounts of extra calories. Ghrelin is the hormone of appetite. And when we don't sleep well, then that hormone really kicks up the next day. And so the combination of not regulating our body metabolism well with the leptin and getting more hungry in the day because we didn't sleep well, potentially are two factors contributing to why a person who doesn't sleep as well might gain some weight. Another question I see here. I get restless legs and anecdotally take magnesium, which we talked about earlier, and feeling that has helped with reducing intensity and frequency. What's the scientific basis for this? Well, the scientific basis so magnesium, as I mentioned, it's one of a number of trace elements that are in our body. Most of the research, as I said, shows that magnesium may have just a very, very slight benefit. Now, iron, on the other hand, as I mentioned, if iron levels are low in the body, that's a much more likely benefit for restless legs. And then there's lots of things people take that they don't realize that might be making the restless legs worse, like sometimes caffeine too close to bedtime, or certain medications that a person might take, like certain cold medicines that have antihistamines can make restless legs worse. So there are different things that can make the problem worse. Let me see what else we have here. I see a question here about what effect can perimenopause and menopause have on sleep for women? Well, I think many of you who might, many women that are on this call can, if you've been either are entering or through menopause, you might have recognized that the combination of hot flashes can sometimes be disruptive to sleep. Sometimes our ability to get to sleep can be affected somewhat just by reduction in estrogen levels. Estrogen has a number of effects on our body and our brain. And we know that estrogen has an effect on our emotional state. And estrogen has an effect on our ability to control our mood. And remember, I said earlier on when we were going around those points of the star, that sometimes mood can change a little bit when a woman is going through menopause. And so the effect may be indirect by mood. It might be direct by hot flashes, or there could be other factors too that I won't really get into today. Yes, someone commented very clearly, and although I cannot personally appreciate it, I know that from my wife's report, as well as working with people over 30 years, night sweats can be a big deal, and there are whole ways to try to address and manage that problem too. Okay, let's see. I see one more question here. And I think we're on the hour, so I apologize if people have to break away. I'll see if I can capture this last question. So Lynn says, I was taking 100 milligrams of melatonin each night, but it didn't help. I had worked my way up gradually. Now I don't take any. Do some people just not react to it? Yes, so the issue is, yes, I'm glad that you're not on 100 milligrams of melatonin anymore. Our body usually secretes about 0.001 milligrams. And for people who have unusual circumstances where their body doesn't secrete enough melatonin, which is about 1 in every 15 people out there, 1 in every 10 to 1 in every 15, then 3 milligrams to 5 milligrams of melatonin can be helpful. But if you're someone who has normal melatonin levels and you are taking more melatonin thinking more is going to be better, you'll discover in many cases it's not. The person who asked that question, I would say you may have normal melatonin levels in your body, and your sleep issues may not have to do with melatonin, but rather one of those other things I mentioned. So if most people, if they're not seeing a benefit by taking melatonin at 5 or at most at 10 milligrams, I certainly would not endorse more. And the people who do benefit are people who tend to have flatter melatonin curves. And I'm afraid there isn't a simple blood test that can be done. We do that in research laboratories, but it's hard to measure in, I will say, real world practice. Okay, I thought progesterone had more of an effect on sleep if the levels are low. Good question. So estrogen and progesterone are both important hormones, and they both can change with menopause. What we know is that estrogen may have effects that are probably more calming, can be more beneficial. Progesterone, on the other hand, can have stimulating effects on our breathing, but also at higher doses, progesterone can actually stimulate the brain too. So that's frequently why if people are on hormone replacement, they're getting both estrogen and progesterone, both because of the effects it has on the uterus, but also some of the effects it has on our emotional state and our brain too. So progesterone, yes, is a hormone that lower progesterone levels may have some beneficial effects on sleep, but there's not simple ways that we can treat that to make that happen. So I think we're now at a point where you mentioned checking iron levels. So I'm going to answer this last question, but then I want to let people have an opportunity to get on with their evening, let their brains wind down so that they can be prepared for a wonderful night's sleep tonight. So the last question here is, you mentioned checking iron levels for restless legs. Would you recommend a home test or a lab test? So specifically, there's one test in particular that I pay close attention to for iron levels in the body for restless legs, and that's a ferritin level. And that's spelled Ferretin, ferritin. So it's one of the blood tests that doctors will order if someone's got an anemia, for example. And if the ferritin level is much below 70 and a person's having any restless leg symptoms, then the person definitely needs iron. Now, this is a point of contention because lots of doctors and other health providers who were trained 10, 20, 30, 40 years ago learned about ferritin, that is, and its effect on our blood system. And we know that iron has a direct effect on the blood system. But there's also lots and lots of places in the brain and in the spinal cord that bind iron for other reasons. So we need more iron in the body for purposes of sleep and restless legs than we do for developing or building up our blood system. So most doctors, if they get a ferritin level and they see the level above 20, they'll say all is good. But if a person has restless leg syndrome, they need more iron than that. And so that's a little pearl that I'm always teaching doctors in training and other health professionals about. So with this, again, I want to wish all of you a wonderful night's sleep. And I hope that this piqued your interest in maybe looking at some of those books or talking with your health providers, and know that all of us have ways that we can adjust our sleep to make it better. And with that, thank you very much.